Assalamu alaikum. Today we'll discuss the management of sepsis and septic shock. According to the Surviving Sepsis Campaign guidelines in 2021, septic shock patients admitted to the ER complaining of chronic hypertension. The symptoms will include fever, mental confusion, heart rates 110 beats per minute, blood pressure 105/40, SpO2 94%, respiratory rate 24 per minute, TLC 6000, procalcitonin 0.05, and creatinine was 2 milligram per deciliter. What is meant by sepsis? In 1991, sepsis was diagnosed as systemic inflammatory response with two or more of the four criteria of SIRS plus infection, and severe sepsis is the sepsis plus organ only one organ affection. While sepsis in 2001, the definition did not change, but the extended list of organ dysfunction increased. In 2016, the definition changed, and sepsis is defined as a life-threatening organ dysfunction caused by dysregulated host response to infection. So sepsis equal organ dysfunction. And the how to screen for those patients in the ER. To screen for those patients in the ER, sepsis should include organ dysfunction, as we said, either brain affection, disturbed conscious liver, lung affection, hypoxemia, or kidney affection, oliguria, or increased creatinine, and the heart affection by cardiac decompensation and hypotension. In 2016, Quicksilver was used as scoring system for quick screening for those patients, including systolic pressure less than 100, altered mental status, and respiratory rate more than 20 beats per minute. And 2 to 3 of these symptoms will define the patient to be screened as to have sepsis. But in 2021, Quicksilver is not recommended as a single screening tool for sepsis and septic shock patients. So to screen and to diagnose those patients, we have other screening tools, not only the TOFA score or procalcitonin. Should we use procalcitonin to decide whether to start antibiotic or not? Never to use procalcitonin as the only tool. Why? With procalcitonin, the onset of rise of the procalcitonin level might extend to 3 to 4 hours unless after the onset of infection. So in those patients, procalcitonin might be negative within the first hour. So according to the clinical conditions and the other laboratory data of the patient and any evidence source of infection, we have to go for antibiotic administration. So sepsis recognition, as we said, if there is organ dysfunction or not, and if there is obvious sign of infection, if both are present, we have to start antibiotic within the first hour. But if there is no organ affection and there is no obvious sign of infection, or there is only organ affection, so sepsis suspicion only is present. So we consider antibiotic within 3 hours if the concern of infection persists. So fever and organ dysfunction equal sepsis. But in some patients, like immunocompromised patient or geriatric patients, there is no fever, only there is organ dysfunction and there is a suspected site of infection. So we have to suspect sepsis for these patients, especially the geriatric patients with mental confusion without the fever. We have to consider sepsis. How should we search for the source of sepsis? From the start, we have to check for any source of infection, starting by the CNS infection. We don't go for a lumbar puncture, but do not delay the start of antimicrobial if the lumbar puncture will be delayed. Sinusitis, sinuses, central line infection. We should go for blood culture. Surgical site infection, or we should go for wound culture, and deep venous thrombosis, the infective endocarditis, the pneumonia, it diagnosed by the chest ultrasound or CT chest, abdominal chest abdominal infection by ultrasound, and UTI by urine analysis and culture. And so this is all the site of infection. And do not forget the skin and soft tissue infection, which might be the major source of infection for, especially for geriatric bedridden patients. The urinary tract infection. How should we select antimicrobial therapy in patients with UTI? If these patients, we found that there is urine analysis, pus cell more than 100, a normal chest X-ray, and as you see, procalcitonin, the first hour might be negative, as we said before. What shall we do for these patients? We should ask ourselves: it's complicated or uncomplicated infection? It's castor related or not, or castor associated or not? What's meant by uncomplicated UTI? Uncomplicated UTI means there is no signs of systemic disease, only there is frequency or dysuria. Complicated UTI, there is fever or sepsis. The organisms imposed are mostly the same, either staph, Klebsiella, E. coli, or Proteus. But if the patient had the symptomatic bacteriuria with suprapubic or intraurethral castor within the past 48 hours, organism might differ, so might be different. So we have to cover for either MRSA, Pseudomonas, and Enterococcus according to the suspected organisms. So in uncomplicated patients, we can go for fosfomycin, nitrofurantoin, and citrim and quinolones only. The levofloxacin or ciprofloxacin, never to use moxifloxacin because it's very poor penetration to the urinary tracts. The risk of MDR, we have to go for carbapenems, and either if there is risk of MDR also in castor related, go for carbapenems plus or minus vancomycin or daptomycin if there is a risk of MRSA. These patients have the urinary tract infection, uncomplicated UTI. There is no risk of MDR, so we can go for ceftriaxone, piperacillin, tazobactam, or quinolones. If the patients have developed septic shock and blood pressure dropped to 80/40, patient diagnosed to have a septic shock, we have to change the antimicrobial to meropenem, 2 grams per 8 hours for in the first 48 hours, and decrease the dose according to the serum creatinine level. What is the goal of hemodynamic management? The goal of hemodynamic management, as we all know, to maintain mean arterial blood pressure more than or equal 65 millimeter mercury, adequate tissue perfusion by measuring lactate, and the most important is the source control of the source of infection. So the hemodynamic management in septic shock include fluid plus minus vasopressor, mean arterial blood pressure 65 millimeter mercury, so there is adequate tissue perfusion or persistent tissue hyperperfusion, so we could increase the fluid or inotropic support if there is the cardiac decompensation. How to choose the fluid for septic patients? In Surviving Sepsis campaign 2021, we should give 30 ml per kg IV fluid for hypotensive patients or patient with lactate more than 44 millimole per liter, around 1 to 2 liters in the first 3 hours. But not in heart failure patients, not a patient on regular dialysis. So we should start with very cautious fluid administration to avoid hypervolemia for those patients. So the fluid bolus we infuse, how to give the fluid bolus: fuse 250 to 500 cc of fluid over to 15 to 20 minutes, and monitor the change of tissue perfusion, mainly the cardiac output. But in patient with there is impairment of the cardiac impairment or renal impairment, we can give mini bolus 100 cc crystalloid over 1 minute to avoid the hypervolemia. The fluid bolus never to give fast in a time less than or in a time period less than 15 minutes, or never to give over a time period more than 30 minutes in patients in a septic patient. So, a type of fluid, do not use saline, gelatin, or hydroxyethyl starch. Use only balanced crystalloid like lactated ringer or ringer crystalloids. And if not, the patient is not responding to crystalloid, we can go for 4 to 5% albumin for resuscitation. So in these patients, we give meropenem, as we said, lactated ringer, 105,000 was given, heart rate was 130, blood pressure remains low. So, but the patient has no central line. If this patient has no central line, we should not delay the administration of the vasopressor. Um, Patient has no central line, so do not delay norepinephrine infusion till CV line insertion. Norepinephrine, we can give norepinephrine safely in the peripheral line up to 6 hours, but do not exceed the concentration of norepinephrine more than 60 mic per ml. Okay. So in these patients, the vasopressor of choice is norepinephrine. Start norepinephrine on which dose we can start with even 0.05 mic, 0.05 mic per kg per minute, and titrates by increasing the norepinephrine every 5 minutes by 0.05 mic per kg per minute. So we can start with low dose, and the patient plus the fluid. No, do not delay the start of norepinephrine till um, for more than 1 hour. Within 1 hour, we have to start norepinephrine if the patient is not catching the targeted blood pressure. So start norepinephrine, as we said. When to start norepinephrine? We said when to start norepinephrine within the first hour, and when to start the what is the maximum dose of norepinephrine. There is a debate around the what is the maximum dose of norepinephrine, but the meta-analysis study found that the maximum dose of norepinephrine might exceed the 5 mic per kg per minute, and it was found that the dose more than 0.7 mic per kg per minute is associated with poor outcome. But the poor outcome might be related in this study to the Apache score and SEPS2 score of those patients, not only the dose of norepinephrine. So the maximum dose, there is no actual maximum dose of vasopressor. Norepinephrine more than 0.5 to 1 mic per kg per minute is considered high dose. And when to start vasopressin? To start vasopressin when the dose of norepinephrine reached 0.25 to 0.5 mic per kg per minute in a dose of 0.03 units per minute, or 0.04, 0.03 to 0.4 per minute vasopressin. What when to add epinephrine? We start to add epinephrine when the dose of vasopressin, when the dose of norepinephrine reached 0.5 1 mic per kg per minute. So if vasopressin is available, start vasopressin before epinephrine. And please keep in mind that telepressin is not recommended in patient with septic shock and is not in another other choice for the vasopressin. So, and these patients lactate level norepinephrine was 0.2 mic per kg per minute. The patient catch the blood pressure for mean blood pressure 65. Lactate was 44 millimole per liter. So the mean problem at a time is the tissue hypoperfusion. How to monitor for tissue hypoperfusion? Adequate tissue perfusion by two factors, serum lactates and the capillary fill time. We should check for pulse every 2 hours. Okay, so if the patient has a tissue hypoperfusion, we can detect it either doing the capillary fill time at the nail beds, either or the sternum or at the knee. And if it's more than 3 seconds in nail bed or 5 seconds in sternum or knee, so there is a high risk for a tissue hypoperfusion. So these patients had a capillary reperfusion test more than 7 seconds and lactate more than 4 millimole per liter, and he received the 1,000 bolus fluids or 100,000 and 400 cc lactated drinker. So to optimize the perfusion pressure, we have three factors according to which the tissue perfusion depends, which will affect the oxygen delivery. Volume status of the patients, the pump function, and hemoglobin. These patients had a normal hemoglobin of 11 gram per deciliter, and the volume status will be measured by the dynamic measures, and pump function will was normal for these patients as detected by echocardiography. So if the patients had a good ejection fraction or systolic function, do not start, never to start inotropic support for patient with normal cardiac contractility. The volume status, the dynamic measures induce how we detect this hypoperfusion, not only the lactate on the capillary fill time. We induce change in the cardiac preload and observe the resulting effect on the stroke volume and the cardiac output. But if we do not have a very measures or the device to easily measure the cardiac output, like the non-invasive cardiac output measuring, or the thermodilution technique, or the using the Swangen's caster. So we can go for simple measurement of the dynamic fluid resuscitation. Also, we can use by ultrasound. We can use the IVC diameter before and after fluid administration. So induce a change in the cardiac output by using fluids, by giving bolus fluids. Pulse pressure with a preload more than 15% change in the preload means that there's increase in the cardiac output. How we do that? We measure the blood pressure, systolic and diastolic blood pressure, and we take the difference between systolic and diastolic blood pressure, which is the pulse pressure. Then we give a patient fluid bolus over 500 over 20 minutes. Then we measure the if there is a change in the pulse pressure more than or equal 15%, this means that the patient is fluid responsive. Another method we can use the also using the pulse pressure in patient but using the passive leg raising technique. In this procedure, never use the manual elevation of the patient's leg, because this might increase the sympathetic tone of the patients due to pain. So it's misleading. It might be misleading. There is an improvement in the patient's hemodynamics or improvement in the patient volume status. We should use a bed with a pivot bed movements, okay, and measure also the pulse pressure before and after, or the pulse pressure variation in the monitor. So how to use the dynamic measurement to assess our patients if we have no cardiac output monitoring, either invasive or non-invasive. We can use either the ultrasound, so the IVC diameter. We can use as we said, the passive leg raising technique, or using the difference in the pulse pressure or pulse pressure variation. So these patients, norepinephrine dose usually up to 0.5 mic per kg per minute, circulate with 33 millimole per liter, and and the capillary fill time was 4 seconds. How and when should we start hydrocortisone? We should start hydrocortisone 50 milligram every second when the dose of norepinephrine increasing zero point 0.2 mic per kg per minute for at least 4 hours. But during the first hour, please do not delay the start of norepinephrine, norepinephrine from the start, vasopressin if available, epinephrine if there is no response to epinephrine within the maximum dose, if we reach the maximum dose of norepinephrine in the first hour, and we should search for the cause. Okay, so if the patient have this ABG of the patient reveals that the pH is 7.25, PCO2 is 25 millimeter mercury, and bicarb was 15 millimole per liter. So the patient has a metabolic acidosis and acute kidney injury. The creatinine was 2 milligram per deciliter. Should we correct metabolic acidosis or not? Okay. According to the Baker study, ICU study in 2018, they have two groups of patients. Patient admitted, both patients are admitted with acidemia, pH less than or equal 7.2, and PCO2 was 45 millimeter mercury, bicarb was less than 20 mole per liter, and we divide the patients into two groups. Group of patients, there is no correction of acidosis, and the other group of patients, they go for sodium bicarb to maintain a pH more than 7.3. And they measure the mortality day at day 28 and need for renal replacement therapy. So the what volume and what type of bicarb they give? They give 125 to 1 to 200 mil of bicarb, 4%. In our country, Egypt, we have only the 8% bicarb, and so we give the half of the this volume in 30 minutes, and maximum 1000 mil per day. Okay, so and the found that mortality in all patients, there is no difference between both group regarding mortality. There is no difference, but it's slightly higher in patients who did not receive bicarb. While in mortality in patients who have an acute kidney injury was significantly high in patients in control group who did not receive bicarb. Also, dialysis in patient with acute kidney injury who did not receive bicarb was higher in control group. So from this, the Surviving Sepsis campaign stated the guideline for adult with septic shock patients, severe metabolic acidosis, and acute kidney injury with a score 2 or 3. They suggest using sodium bicarb therapy for this patient, but not only use bicarb to correct acidemia, but there is no kidney injury or there is no indication for dialysis, but we have to correct the hyperperfusion, the increase the dose of fluids, increase the dose of vasopressor or inotropes. So in septic shock patients, what about if the procalcitonin increase and not decreasing, we have to continue on the antimicrobial. In these patients, septic shock patients, the procalcitonin in the first day, as we said, that procalcitonin might not increase as in the first start of the discussion today. Procalcitonin was 0.05, and in the first day, procalcitonin was repeated, and it was found to be 10 milligram per deciliter. Then in the 7 day it become 2 milligram per deciliter. How can we use procalcitonin to discontinue antibiotic? As we said before, that if the patients have procalcitonin level less than 0.2, the cutoff point, or 0.5 nanogram per liter, we can stop procalcitonin, milligram per deciliter, we can stop procalcitonin. Or if the procalcitonin level decrease from 80%, or it's less than 0.25, and not more than zero point 0.5. Also, we can encourage antibiotic discontinuing the antibiotic. While if the procalcitonin level decreased to more than 80%, but the actual value of the actual concentration is more than zero point 0.5, better to keep on the antimicrobial till decreasing the level of procalcitonin less than zero point 0.5. Okay, if there is no decrease for more than 80% and there is increase in the procalcitonin, we have to change the antimicrobial. So in this patient, procalcitonin decreased from 10 milligram to 2 milligram per deciliter. So there is decrease only 80%, but procalcitonin still more than zero point 0.5. So we should continue on the antibiotic until the level of procalcitonin decrease less than the zero point 0.5. As we know that there is a lot of recommendation regarding the surviving sepsis campaign, and please follow up the guidelines while you are managing a patient with septic shock. Thank you.